Our topic today is architecture of a healthcare system for Canadians. Dr. Walker is a professor in the departments of emergency medicine and family medicine in the School of Medicine, cross-appointed in the School of Policy Studies at Queen's University. At Queen's, Dr. Walker has also chaired the Principals Commission on Mental Health. He's a member of the consultant staff at Kingston Health Sciences Centre. Born in England, Dr. Walker graduated with an MD from Queen's University and was certified in internal medicine and awarded a fellowship in the Royal College of Physicians and Surgeons of Canada in 1975. From 1999 to 2010, he was Dean of the Faculty of Health Sciences, Director of the Medical School, and CEO of the Southeast Academic Medical Association. Dr. Walker has been President of the Canadian Association of Emergency Physicians, President of the College of Physicians and Surgeons of Ontario, Chair of the Council of Ontario Faculties of Medicine, and served government as chair of an expert panel on SARS and infectious disease control. He's also served as the inaugural board chair of the Ontario Agency for Health Promotion and Protection, as an advisor to the Ministers of Health on policy areas concerning public health and aging, and more recently to the Auditor General for Ontario and Ontario's Long-Term Care Commission. He's vice chair of the board of Providence Care Hospital in Kingston, chair of the Frontenac, Lennox, and Addington, Ontario Healthcare Team Transitional Leadership Council, and is currently a special advisor to the Principal Dean on COVID-19. Clearly, we have no one better suited to speak to us today on architecture of healthcare in Ontario and indeed in Canada. Welcome, David, and we're delighted to have you here.
Thank you, Martin. Thank you very much. And thank you to everybody for taking the time to participate in this. It's a great honor. A mentor of mine many years ago, some of you may remember him, now long departed, Dr. Robert Buckman, was associated with your organization, and he had made an impression on me that was long lasting. I'd like to talk today a little bit about the way in which we provide this very important social program, which is healthcare, to our population. I would like to draw the analogy that we have a fleet of boats, fishing boats, that are in distress in a storm, and they are signaling that distress. And I will identify the distress signals and then try to dive into each one a little bit with perhaps, I hope, some elucidation of ways in which we may move forward in a different direction. That there is a problem, I think nobody could be in doubt. And I will go to my concluding comment as I begin, and that is that when all is said and done in Canada, absent a foundation of effective primary care of our population and absent effective social care and community care of our population, our health system will fail to deliver as it should, particularly in an effective fashion. Every community in the developed world knows this. We know this, and yet this is now in disarray. So what are the signals of distress that our little fishing fleet is showing? I have a number, and I'll go through them one by one and then return in more detail. The first is primary care. Having a family doctor or a nurse practitioner to do what they do so well. So there is a major problem with primary care, and I will elucidate that in a minute. The second, and I don't think, assuming you have a family doctor, you must move on to the next point, which is that the emergency departments of Canada are crowded and sometimes inaccessible, and sometimes now closed. This is clearly a problem. If the one service that one desperately needs in times of crisis is unavailable, this must be the ultimate canary in a coal mine that would suggest that we have a problem. The third is a particularly political problem at the moment, but also a functional problem in Ontario and the rest of Canada. And that is the fact that we have hundreds, in fact, thousands of mostly frail elderly folk who are languishing in acute care hospitals, who no longer need the services that led them there in the first place, but are awaiting either a return home with home care, awaiting transition to other providers, or waiting for long-term care. They are in the wrong place at the wrong time, and it is a problem. And I will get into that too. I mentioned long-term care. COVID exposed many of the major failings of our healthcare delivery in Canada, and none more so than in long-term care, where the majority of the people who died. And so I will get into long-term care as a signal of distress in our system. The next item I'll mention is wait times. Anybody who's waiting to have cataract, hip replacement, a knee replacement, an investigation, and is put on a wait list and waits, realizes that we have a little bit of an issue. And then mental health and addictions, again exposed by COVID, but certainly long since before COVID. At the horrible end of this, the persistent deaths from opiate overdoses, running twice now at the rate they were before COVID, speaks to a system in disarray. And then we've heard a lot about health human resources. Where are the workers? Why aren't they not there? Why do we not have enough to do what we need to do? So those are I think any reasonable person would see those headlines as signals of distress in what should be a system of integrated care of our population, from the preventative maintenance through to the quaternary prevention elements. So going back to primary care, a few stats. It always struck me as odd in a publicly funded system that if a family moves to a town with their children, that there's rarely a problem getting their children enrolled in a school with teachers. We would, I think, find it astonishing if that family were told, well, you're on a waiting list for a school and teachers, and you might get in next year, or you might not ever. We would find that to be astonishing. But that same family moves to that same town and cannot find a family physician and is told, well, it'll be worse next year, actually. During COVID in Ontario, 385 family physicians retired, assuming that they had about 1,000 patients each on their rosters. That's over 1/3 people who now don't have a family physician. That's 3% of the family physicians in Ontario. We're approaching a majority of family physicians who are over 50, and we're going to see an enormous shortfall in the availability of family physicians. Interestingly enough, in medical schools, medical students have very little appetite to go into primary care. The last 2 or 3 years, we've seen this falling away dramatically. And even those who have selected family medicine as their training, we are seeing them pursue other than comprehensive primary care as they graduate from those programs. We have 17 family medicine training programs in Canada, each associated with a medical school. And in some of those family medicine programs, which produce dozens, if not many dozens each year, 0 would be going into comprehensive primary care. They go into emergency care, they go into hospitalist work, they go into sports medicine, they do a variety of things. But we are seeing a massive drop-off in the interest of young physicians going into primary care. We're going to lose about 1/3 of our existing GPs in the next 20 years. And this is the bedrock of our healthcare system. In Kingston, I noticed the other day, we have a stat from one of our hospitals, at KHSC. We have 300 new cancer patients in our KHSC cancer clinic. 300 new cancer patients, newly diagnosed, who don't have a family physician, which makes their care very complicated. So we need to analyze a little bit about why young people don't want to go into primary care. And I think when you talk to them, it's pretty evident. They do not wish, as their predecessors did, to have to find a practice, to buy or rent a building, to create staffing rosters, hiring contracts, software for their hardware for their practice, the administrative burden of this, let alone the complexity of being in primary care. They would rather go to a turnkey operation. They can go into anesthesia and go to work at 8 in the morning and go home at 4:30 in the afternoon and be on call one night a week. No problem, no overheads, no complexities. This has become a major issue for those who would normally go into primary care. Not only that, in Canada, we do not deploy our primary care practitioners well. They're all independent operators. Family physicians can work wherever they wish to go to work. And they're not necessarily organized to care for an entire population in aggregate or individually. So we have a deployment issue, we have a retention issue, we have a recruitment issue, and we have an organizational issue. And unless we address this in a fundamentally different, fashion, we're going to be in big trouble. So primary care is I think, the first significant signal of distress. Other countries have approached this far differently. In most of the Nordic countries and many European countries, primary care practitioners work in groups with other providers, social workers, dietitians, pharmacists, psychotherapists, nurse practitioners in community-provided resourced facilities, and are responsible for the care of geographically defined populations. They're also responsible for after-hours care and urgent care 24/7, which relieves the emergency department. That, I think, is a model that we need to think about. Those physicians are, generally speaking, salaried with bonuses for performance and often salaried, often pensioned, as they are in Britain and Australia. So we need a greater degree of accountability and organization in primary care. The second signal of distress I mentioned was the emergency department. This, I think, is, as I said, a canary in the coal mine. It is a significant issue. There are many myths about this. The standard myth that is believed by ministers of health and much of the public is that the reason the emergency department is overcrowded is that there are many people there who should not be there. Now, it's hard to dispute this. There's no doubt that if you look at the stats, there are about a quarter of the patients there who could be seen elsewhere. These are considered to be less urgent issues, sprained ankles and runny noses. But they, in fact, do not contribute significantly to the overcrowding in emergency departments. They could be seen elsewhere, there's no doubt, although you would need somewhere elsewhere at 2 in the morning if your nose is bleeding to be seen, which would mean adding another availability point. There is no doubt that getting to your family doctor after hours can be a problem. I noticed my family doctor, who I like a lot, her practice offers after hours care. They're very proud of this, after hours care from 4:30 to 6, Monday to Thursday, and for an hour and a half on Saturday and Sundays. All of that by appointment. So I'm not quite sure that qualifies as after hours. But in any event, in the emergency department, there's no doubt that there are some patients there who could be diverted elsewhere. Much more to the point, though, the reason that if you do that, you'll still find your emergency department is tremendously crowded. The reason it's crowded is that if you were to walk through my emergency department today, which has got 46 stretchers, you'd find 20 or 25 of them would actually have patients on those stretchers who've been there for half a day or a day and a half. They've actually already been seen, assessed, treatment has begun, and they've been admitted to hospital. But there's no bed upstairs for them to go to because the hospital is full. And so the emergency department is now working out of half of its available capacity. So this is far more the serious problem. This is why you see people lining the halls of emergency departments. This is why you see offload issues where ambulances are lined up. The other day, there were 12 ambulances outside my hospital emergency department trying to offload patients to a department that had no additional staff, no additional beds, and there was nowhere to put these patients. So we have an issue here which is actually far more significant than diverting a few people with runny noses. who actually take minimal time, minimal resources, minimal nursing time, minimal doctor time. But in fact, it is these folks who are seriously ill, who are requiring an emergency department visit, but the department is chock-a-block because the hospital itself is full. And that has its ramifications in terms of deferring surgeries that are being scheduled. So the third problem is that in Canada today, the staff in our hospitals and obviously in the emergency department, ICU, and other locations are exhausted. We have some conundrums around staffing, health human resources. The stats would show that the situation is not as bad as it sounds and seems to be and is. However, on the ground, our hospitals are struggling with not enough staff of various sorts, particularly nurses, registered practical nurses, and personal support workers. So that adds to the complexity of the overcrowded emergency department when you may have to close one of the units within the department because of lack of staff. And there are experts who are trying to understand where these staff have gone. The number of people who've left and the numbers coming in seems to be more or less equivalent, but there are some complexities to this that are hard to understand. The third thing I'll mention is the poor folks who we designate alternate level of care. So these are folks, as I explained earlier, who usually go to emergency departments for a reason. And sometimes it's a non-medical reason. They cannot be looked after at home anymore. They've become increasingly confused. They may have dementia. Maybe their caregivers become unwell. Maybe they've fallen and have a fractured pelvis. Maybe they've got a pneumonia. But they are going to the emergency department. What it is that brings them there is addressed, but they're not well enough to go home, which usually means that they linger in the emergency department, deconditioning and getting more confused, while a bed upstairs is found. And that bed upstairs is often a bed that was going to be used by someone awaiting surgery or some other procedure. And so this becomes problematic. And then they languish. They may have to have an emergency referral for long-term care. They may be already on a list to go to long-term care. They might benefit from going home with home care, but home care in our country, particularly this province, is very sharply curtailed. They might benefit from going to a transitional care unit, such as we have in Kingston, where they're assessed, restored, have physio, and then can go home with home care. But one way or the other, they remain in the acute care hospital. And in Canada, generally speaking, about 15 to 18%, sometimes rising to 20% of our acute care hospital beds are filled with these folk who do not need to be there and actually are getting worse while they're there because this is not the place they should be. They need social and other supports, medical, physio, nursing support in a setting, but not an acute care setting. Our acute care hospitals are designed to treat life and limb threatening and urgent medical and surgical matters. They're not designed to be long-term care facilities. So this is an issue that is tremendously problematic. Canada has fewer acute care hospital beds than many of our comparator nations. And when you occupy up to a fifth of them with people who don't need to be there anymore, you really can, it's like cutting one leg off a running back. So this is a really significant problem, and there are some ways to address this. I did some work for the government some years ago, which clearly didn't take. But there are solutions to this, which need to be really addressed. In many ways, this is a lack of an effective primary care system that will allow elderly folk to be monitored and kept at home. During COVID, much of the preventive maintenance that we all need was lacking. Our older population need regular assessments and care, a bit like my elderly car. If I don't put it through maintenance from time to time, suddenly the wheels start to get wobbly and start falling off. So there's a significant problem we have with the care of our elderly population, and we are not doing them a good service by allowing this to occur. The next signal of distress is long-term care. We all saw the devastation in long-term care due to COVID, which in retrospect, of course, was seen to be due to crowding, lack of effective public health measures, poor staffing, uneducated staffing, poor medical oversight, loss of integration or lack of integration with acute care. And we saw staggering death tolls in our provinces in the early days of COVID. Issues to do with ownership have come up, the variability of care related to whether these institutions are private for profit, private not for profit, or publicly owned, led to much discussion. The fact is, we in Canada, we tend to, we pay so much lip service to long-term care, we do not support people in their homes. Denmark, for example, passed legislation in 1989 forbidding the construction of any further long-term care capacity, and they've stuck to that. They put their money in home care. They provide extensive support to people in their homes or the equivalent of their homes, clustered living and other models, but to keep people out of long-term care. They do use their long-term care for those who really need it. Not only that, members of the elderly population can actually go to long-term care for a couple of weeks a year to get assessed and restored, have medication reconciliation, physio and other things, give their caregivers a break, and then they go home. We don't use our long-term care the way it should be used. It's a one-way ticket. And in fact, by the time people get there, the average length of stay is 1.5 years, which means that is likely how long one will live when you go to long-term care. So we need an aging strategy that would embed better resources in home care with better community supports. We need planning for dementia, since so many of us will get a dementia of one kind or another. And we need a rational use of other supports along with long-term care, with strict accountability for standards, with inspections. It was intriguing to me that just as COVID began, we discovered that the usual model of inspecting long-term care facilities on a regular basis to see if they adhere to the standards in the various acts, legislation to which they were supposed to adhere, was actually canceled. And that inspections of long-term care facilities in Ontario became basically complaint driven. So if there was an issue, there would be an inspection related to that issue, but there was no overarching comprehensive assessment of these facilities, which I would have thought was a recipe for disaster. Another of our boats has got a distress signal, and that's to do with wait times. And I don't know how many of you have members of your family or yourselves who've been waiting for things. We're good at that in Canada. We wait far longer than other places do. First of all, if you're waiting for something in healthcare, maybe you're waiting to see a family doctor. If you don't have one, you've got a really big problem, which gets back to my premise or my conclusion that absent a strong primary care system, we're going to be in trouble. But assuming you have a family doctor and you have an issue that needs some sort of specialty care, particularly surgical care, you then need to see a specialist. And we have a patchwork quilt of systems of referral, which is absolutely crazy. Your family doctor might have a favorite orthopedic surgeon and tell you, well, I'll refer you to Mary. She's really good at knees. And so you then have to wait to see Mary. You may wait quite a long time. And by the time you get to see Mary, she may say, well, where's your x-ray, which has been lost? Or where's your MRI? Well, I never had one. Well, I like to see an MRI. So you will get you on a wait list for an MRI. And by the time that's done, then Mary's sort of forgotten about you, but you then call and, oh yeah, we remember, we'll see you now. So she sees you a couple of months later and says, yeah, well, I think you probably need a knee replacement. I'll put you on the list. There are many more efficient ways of dealing with this. One of the tragedies of this sort of system is that sometimes after a long wait to see a specialist, this is particularly true with people with back issues, you wait 2 years to see a back specialist who tells you that actually that's not what they do and you don't actually need surgery. Meanwhile, for 2 years, you've not been doing what you might have been doing to actually get yourself better. So we need a far more efficient system that is used in other jurisdictions with a common referral system to a pool of experts who will assess you, make sure the right investigations are done, and then you go in the right direction for whether you need surgery or not. And if it's surgery, who does it? And it's out of a pool of surgeons, not waiting for the one. I know surgeons whose buddy in the next office are inundated with a long wait list, and they have a short one. They do the same thing. They do them just as well. We have very well standardized providers in this country. So we have a tremendous problem with long wait times. So we need some sort of central booking. We need proper triage, multidisciplinary assessment with not just the specialists, but others. And as other jurisdictions do, I firmly believe that it is safe and appropriate to actually build out of hospital surgical ambulatory centers, which should be linked to hospitals with the same surgeons and other staff, but do some of this stuff outside hospitals. Hospitals are pretty noxious places these days. People have got COVID, they've got other diseases, many infections, lots of bugs. If I'm a healthy person needing a knee replacement, I'm not sure I want to go in there and have this done. I'd rather go down the street where there's a full service surgical center that can do my knee. These could be built by the private sector if you like, as long as my OHIP card works and I don't have to pay a premium and I'm not jumping the queue because that's not a Canadian value, but there's a standard queue with a standard intake system. The next topic, which I'm not going to dwell on, and which is unfortunate because I'm not an expert, but it is clearly a problem. You could talk for weeks, days, months about mental health and addictions. And I know Martin is interested in this, and we all should be. And COVID, of course, has been a tremendous burden to those who have acquired or have mental illness. Our society's been under strain through this. I think we've all felt it to one extent or another. And for those less fortunate, the fallout is drastic and dramatic. And we're seeing daily deaths from opiate overdoses. We see contaminated illicit drug supply, certainly in certain parts of Ontario now. Gummy bears that usually would have a little THC in them now have fentanyl. So kids are getting sick and some people are dying from eating gummy bears. This burden is intolerable. And again, it speaks to the fact that we do not invest in a variety of known interventions, safe injection sites. I saw a stat that in the last, I forget what period of time in Kingston, we have a couple of safe injection sites. There were 324 resuscitations in the safe site of people who otherwise, if they'd done this down the street, would have died. I think it was over the course of a year and a half or something. We need to have policy discussions about decriminalization, as Portugal has done, I think, quite successfully. We certainly need to embed greater social supports. We pay so little to social care in this country, far less than our OECD partners do. And we have burned out providers, caregivers. So we have I think, another recipe for disaster. It's interesting when you start seeing doctors talking about housing, homelessness, you begin to see the social determinants of health, which are far beyond my prescription pad, but clearly play such a massive role in this destruction of members of our society. The next signal of distress, the last one that I will talk to a little bit, is the health human resource one. It's an interesting phenomenon of a pandemic that, as the pandemic becomes woven into the tapestry of day-to-day life, as this one is, as we know, COVID will always be with us. It's now added to the list. It's still a very big item on the list of those that makes us sick, particularly those who are unvaccinated or otherwise vulnerable. But nevertheless, COVID has challenged our health human resources tremendously. I both feel guilty, but thankful that I'm no longer in the clinical workforce. But my colleagues who have been in ICU and emerge on the front lines of street health, in the acute care medical wards of our hospitals, are exhausted. You can only imagine that on every COVID possible case, you're fully gowned, sweating, can't go to the bathroom easily, missed your lunch, you're working an extra shift because your colleague got sick. The public are getting upset and sometimes angry and occasionally violent. And you're doing more work than you would normally do in a very difficult setting. So naturally, people are actually exhausted and leaving, or they're becoming absent because they get sick. And we have an enormous health human resource problem. Now, this isn't just a COVID issue. COVID has thrown a light on it. But we have known for years that the demographics of healthcare providers would suggest that a whole bunch of us are over 50, over 60, over 70. This is the nature of the demographic. And we have not attended to this. We don't even count in Canada how many of what kind of who we have, let alone try to identify what we might need tomorrow or in months and years to come. We know that we have a massive shortfall of personal support workers. These are the people who would make long-term care safer. These are the people who are desperately needed in home care. In fact, the majority of the time in home care, that is what you need. You need a personal support worker to help you with your daily living, with your bathing and with your feeding and with your clothing. And we haven't addressed that in the least. Not only that, we've underpaid and not respected those who labor in this particular field. We've not taken advantage of ramping up nurse practitioners who can do many of the things that family docs do and work closely with them and make that much more effective. We haven't addressed the fact that many senior caregivers, particularly physicians and nurses, are being replaced by junior people who, just because they are less experienced, are not as effective and efficient at looking after large numbers of patients. So we have a tremendous issue with this. I mentioned the problem, particularly with the lack of interest in young physicians going into primary care. There is tremendous interest in young people in Canada going into healthcare fields in general. The numbers of applications to medical school and nursing school and physio schools and OT schools has skyrocketed. But somehow we need to translate that into effective health human resource planning. There are thousands of internationally educated healthcare professionals in our society living in Canada for whom regulatory approval and licensure is really obstacled. And that needs to be addressed as well. I think Canada has to be rather careful about denuding other populations of their healthcare workers, which we've been criticized for before. And we have tremendous capacity to create our own, but some admixture of internationally trained and native trained workers is critical. I'll draw to a close in a moment. I would point out, Martin and I were chatting before this, throwing money at this problem has been done many, many times before. We need a radical rethink about the way in which we provide our healthcare services, and in particular, primary care. We spend a lot in Canada. If you look at the OECD figures, we are middle to high on what we spend on healthcare per capita, and we are in the usual comparisons of 11 nations. We are 10th in terms of how well we deliver. The 11th is always the United States, and Canadians, I think, quite happily state we are proud of our healthcare system. It's better than the Americans, where tens of millions of people have no healthcare coverage. And they have far worse stats on years of life lived, mortality, infant mortality, maternal mortality. So we take comfort in the fact that our large neighbor to the south has a worse system than we do. And it's a bit like saying, you know, we won the World Cup of hockey, we beat the Americans again. The fact of the matter is that 9 of our comparator nations that are much more like us do far better in terms of value for the money that they spend. I think we need to think long and hard about that. We need to think about the way in which we govern our various provincial systems and the way in which we can make our systems accountable for better results than we have now. There's often the sort of, well, let's have a public-private mix. We actually have a more private system than most of our comparator nations. Only 70% of the services we provide in Canada are publicly funded and covered by our publicly funded insurance systems. Most of our comparator nations have a far higher proportion. They include drugs, they include dental, they include home care, they include psychotherapy, and we don't. So we have a very large stream of privately funded healthcare already. The argument is that if we allow people to pay cash for various services, that we would decompress the system somewhat. I've failed to convince myself that that would be a solution. It might make some wealthier people feel better, but I don't think it's going to stop a logjam in the emergency department. And it will not stop the deaths from opiate overdoses, and it will not stop a variety of the other distress signals that I've described. So I'll stop here. I promised to speak for 30 or 40 minutes, and I see that I spoke for 37, and that's probably far more than I should have. And I'm happy to stop now and take any questions or engage in conversation.
Great. Well, thank you so much, Dr. Walker. After listening to you, I'm not sure whether I'm not feeling very hopeful about the Canadian model. So let me ask you, is there a bright spot anywhere in our healthcare system that you can identify?
Well, I think there is. I think there are. And I think we've learned a lot through COVID because it has been a burning platform to help us transform. There are initiatives in my province of Ontario, the creation of Ontario Health at the upper level, which pulled together all of the agencies that were engaged with healthcare, and which has spawned the nascent development of Ontario Health Teams, is, I think, a hopeful thing. In theory, these Ontario Health Teams are made up geographically of all of the provider organizations and individuals that you need to wrap around our population, integrate the care that's provided to the population, measure the care you give to the population, preferably on a digital platform so that we all know what's going on, and then smooth the transitions through the complexities of healthcare, which are in fact hard to make more simple. So I think in Ontario Health Teams, I think some of the data collection and analytics that we're beginning to move toward are helpful. I think the fact that we now suddenly recognize that our human resources are fragile is useful. As usual, these burning platforms do make us think quite carefully. When you drive to your local emergency department in Perth and find a sign on the door saying we're closed while you have chest pain is a pretty sobering moment that would make the public think, this is because there aren't enough nurses there, or not enough doctors there. This makes one begin to question. There are many of us who have been talking about what I've been talking about for years now. The rebuilding of public health I talked about with governments back in 2003 when I led the SARS expert panel. Public health was rebuilt, but then there were no more pandemics for a while, so it began to languish, and we had a real jerk on us when COVID came along. So we need to think about history and we need to think forwards, but I do think there's hope, and I think there are an awful lot of people now thinking really hard about this. And one of the, I hate to say it, good things about COVID versus SARS is that COVID has lasted so long and is not going away like SARS did, and will be an added stressor to us through this winter and likely others as well through the summer, that it keeps us focused on having to address these issues. And as you say, this is not just a matter of more money. This is a matter of people actually radically restructuring this. Is it appropriate that we have tens of thousands of family doctors in Ontario who are completely free agents? I mean, many of them my friends, colleagues, who can practice as they wish, where they wish, when they wish, doing what they wish, at enormous cost to the public purse, rather than deploying them in groups with others, nurse practitioners and others, to actually care for a defined population with accountable standards of care, accountable standards for when they provide it, round the clock, however, I believe there are things like that that could be done. They're very tough. Canadians hold our healthcare system to be sacrosanct, so our politicians don't like to touch it. If the average Canadian thinks we've got a really good system, a politician's not going to stand up and say we don't. Joey Smallwood once said, "I never mention healthcare because I lose votes."
Yes. And so the question, just to follow up on that, and I know we have others who are posing some questions, is who drives this change? I mean, what you're talking about makes perfect sense. You're an incredibly smart guy who's been in key places. So how does this shift get driven? You know, for example, just taking the primary care issue.
Yeah, it's frustratingly difficult to answer that question. We have somehow or other arranged things with so many players, with so many different accountabilities and incentives that go in all sorts of improper directions, that it's very hard for anyone to actually change the pattern. You can put more money into the system. It's very difficult for government to do it. I mean, government is an insurer, basically. I mean, the government doesn't run the healthcare system. Government pays for the healthcare system. Mm-hmm. The hospitals are independent, sort of. They're not owned by the government. The doctors are certainly independent. So you have to use money to change it, which is unfortunate. I think many of us in the system believe that it is those of us in the system who need to show that we can do it better. We need government to get out of the way to some extent, because they get terribly nervous if you start to do things in a different way. Mm-hmm. But set some goals, set some standards, set some outcomes, and let people get on with it. I mean, I believe in a regional approach to this. I would have regional health authorities made up of reasonable people. I would give them the entire budget. I would say, Southeastern Ontario, here is your $3 billion, or whatever it is that we spend a year for doctors and nurses and drugs and hospitals and long-term care and primary care and social care and street health and everything. You guys work out how to spend that money, but you've got to make sure that people are healthier this year than they were last year, that the opiate deaths are down, the long-term care patients are happier, the ALC rate has come down, that your surgical rate has gone up. Now, you can do it as a pilot. Canadians love pilots. And often the pilots work, but then we don't copy them. We don't scale them up. And take, cheat like crazy, cheat from other jurisdictions. Other people in bits and pieces do this really well. There's examples in New Zealand about how primary care is all powerful, and the Pegasus project there, it works really well. I don't know if you can move it here, but the French have got some good ideas. The Danish certainly do. The Swedes do. I'm not sure about Britain at the moment. It seems to be in a bit of a problem, but there's no magic here. There are ways to do this, but it takes tremendous political will, which includes, in my mind, actually blowing up some of the most powerful organizations like my own in medicine that needs to reconfigure itself.
Okay. That sounds like there's a whole other webinar on that topic.
Yeah.
And so here's a question from Marty Shoemaker. Having helped a number of immigrant physicians maneuver through getting licensed in Canada, the restrictions are immense and they're waiting to work as they did in their home country. Have you seen any changes to address the quicker use of immigrant and well-trained doctors now unable to practice, and including nurses and other practitioners who are also immigrants?
Yeah, I think it's always a thorny problem. In Ontario, certainly the government instructed the regulatory colleges to get a move on in terms of assessing these folk. I mentioned there were 1,500 or 6,000 internationally educated nurses who were in the country, or I forget, or the province. And the College of Nurses was laboriously looking at their qualifications, identifying where they needed upgrading and where they didn't. And the same with physicians. it is challenging. I know when I was Dean of Medicine, our medical school participated with the others in assessing internationally trained physicians. And it was a little disconcerting. I mean, on one end of the spectrum, it was obvious that a well-trained internist from Mumbai was well-trained and could slide right into a role in Kingston or Toronto or Sudbury. But what looked like a well-trained physician from Vienna actually had major gaps in their education, and their training was entirely different from ours. So it's much easier to assess a locally grown person who's done all the things we are used to than it is someone who comes in and says, I'm fully trained. Even though on paper they may have enormous gaps. So you do have to be a bit careful. I mean, Canada is very lazy about making their own doctors, I should point out. About a third of Canadian doctors are trained somewhere else. I mean, we're a wealthy country. And I'm an immigrant myself. I'm quite happy with that from my own point of view, but we should be seriously thinking about how many docs and nurses we make of our own, so that when there's a surge need like a pandemic, that we don't have to beg the rest of the world to give us their nurses and doctors, which I think sometimes verges on unethical, and we've done that in the past. I remember when we denuded part of South Africa of critical care nurses and doctors. There were like millions of people suddenly had no ICU. So yes, but nevertheless, we need to have much more nimble and elegant assessment methods. But again, when everyone's working flat out, taking a bunch of expert nurses and doctors to step aside and do some assessment of people who are need to have training assessment is also difficult. You need to somehow build that in to the tapestry of day-to-day life, as we've tried to do in the past.
Right. And as you mentioned, my own niece actually went to be trained as a physician abroad and is now working in the United States. And I think, there's classically someone who would have loved to have been here.
Well, we have, the last time I looked, there were 3,500 young Canadians training to be physicians overseas. In Australia, in Ireland, in the Caribbean, all over the world, and they eventually come back, but coming back is difficult. It's easier to get into the States, and eventually getting back here, and people often lose their way along the way. That strikes me. These are not kids who are not good enough to get into medical school in Canada. We have 5,500 applicants to Queen's every year, and we have 130 spots.
Exactly.
Yeah, so don't tell me those 5,000 are not intellectually capable of being physicians. The vast majority would be. I mean, I'm not suggesting we take in 5,000 all at once, but this is a crazy waste of human resources when we have fewer docs per capita in Canada than most other countries. I don't think the solution to our problems are more docs, generally speaking, actually. I think they're far more fundamental. But we certainly need to look closely at why people don't want to be family doctors. And I think we need to, if we can't make family medicine interesting and rewarding, we have a really big problem. It's a bit like suddenly finding we don't have airline pilots, because they don't want to do it anymore. I mean, you need to say, why not? I mean, what is the issue? My dad was a country GP for his whole life. He loved every minute of it. I mean, why? What's going on here?
Yeah, absolutely. Another question that comes up is, thank you for that response. Your thoughts on home care and how it could change to support a better healthcare system.
Well, as it stands, home care is cheap compared to the alternatives that people need, because the default is if you don't get home care, you either deteriorate and you end up in a merge, or you were in a merge and can't go home because of lack of home care, or you've had surgery and you can't go home yet and then you get worse. Home care is cheaper than a bed in a hospital. It's cheaper than a bed in long-term care. It's partly cheaper because we don't pay the people who provide home care very well. So actually, if we start paying them properly, it will get more expensive. But nevertheless, we provide so little publicly funded home care that it's almost laughable. I mean, a frail elderly person who's living alone, a little bit confused occasionally, might get 3 hours a week to help them with bathing, and make sure that their pills are lined up right, is not going to work for long. And there are better models elsewhere. first of all, making sure that that individual who's living alone might live in a setting where they may be in one unit themselves, but clustered with others, with a common personal support worker for a bunch of units, living in other congregate settings with a nurse practitioner visiting once a week to do a little checkup of people, again, preventive maintenance. Many of our elderly folks, even though they're frail and elderly, can use remote monitoring facilities quite well. You see people who will do their blood sugars or their whatever remotely with their devices that link into a system of care. We also have a primary care system, notwithstanding the people in it who are wonderful, but it's very reactive rather than proactive. You know, there should be invasion of people more than waiting until you hear that grandma's being sent to emerge because she fell in the bathtub again. So I believe firmly that we've tilted this entirely the wrong way. I would put far more money into home and community care. I'd integrate the community service organizations, of which there are dozens and dozens and dozens, all doing their different thing together in supporting people in their homes. That's where people want to be. I don't know anyone who stands up and says, I want to go to a nursing home, especially now, right?
Exactly.
So if staying at home with supports and good primary care, as I said at the outset, must be the foundational solution to these problems, however we achieve it. And if we don't, we'll have crowded hospitals and crowded emergency departments and opiate deaths and a burned out workforce.
Indeed. Assuming, if you had a crystal ball and assuming that, there was some goodwill and an openness to make some changes, to correct some of the problems that you've identified today. I mean, how many years until Ontario has a good functional care system would this be? Assuming we're be able to align those ducks up in a row.
Yeah, I don't know, Martin. It's hard to tell. I think I don't for a minute dismiss government's wish to see things work better. Everybody's worried about money. Governments don't have a lot of money. There are some things on the margin I think governments could do differently. And I think Bill 124 in Ontario that capped public sector wages to 1% in the face of inflation running at 5, 6, 7, 8% was symbolically a bit of a slap in the face to the health human workforce. But the government of Ontario has predicted that healthcare spending will increase by 2% a year in the next 5 years. It has never been as low as 2% a year. Inflation alone, population growth alone will consume that. It is incredibly difficult to limit healthcare spending to anything less than 5%, sometimes 3 or 4%, but then it always reverberates back up again. So I don't believe Mr. Ford believes for a minute that he can restrict the funding by that amount, although I think he's very nervous about labor discussions, but not just in healthcare, but in all other public sectors. I do believe that we will be forced to do things differently by dint of circumstances. And I think that won't be just government-led. Again, if government allowed, I think you would see more innovation in order just to survive. And I think some of that innovation will be good. When I watch the way we, in the hospital, try to redistribute, the resources we have to deal with these moment-to-moment crises, you see tremendous innovation, different ways of doing things. Let's do more surgeries outside hospitals. It shouldn't actually cost that. It should cost less. I could negotiate with a team of ophthalmologists to do 400 cataracts at a lower than the OHIP rate. They have to provide the building, but I'll give them a lower rate, but I'll guarantee them those cases. They won't be stopped because of lack of beds in the hospital. So they'll actually do more cases at a lower cost. There are ways to do this, but again, government gets so nervous about that. Let's do hips and knees outside hospital. Let's do colonoscopies outside hospitals. They'll be easier because you will be internally cherry picking. No one's going to be disadvantaged, but the healthier people will be done more quickly with less blockage, more effectively for less cost. There are ways you can do this, save money. But it takes some bravery to do it.
Right. And given the structure of our healthcare system, and I know as we look at some closing moments in our conversation today, so as we look at these kinds of changes, the political system, as you say, that healthcare needs to be removed from more of the political system because the politicians are looking at their re-election. So they're on this 4-year cycle, and there's no incentive for them to be looking at a longer view. How do we navigate that?
Yeah, I do think there's an argument. I think Ontario Health may be the beginning of this if it's done right. Alberta Health's done the same thing. You dislocate healthcare services from government. Government funds it, and government very clearly identifies what outputs and outcomes it wants, but then hands it off. The Brits do this for the National Health Service. When there's a problem, it's not a political problem, less of a political problem. They blame the National Health Service. Well, give them more money or give them better tools, but it's not the minister's problem so much. I believe that we need to pursue that model a bit more, and I would then regionalize it and hold people firmly accountable for results. You can't just not have a system after hours of looking after people and saying, go to emerge. You won't get paid if you do that. There are 30 of you, so one of you should be on call that weekend and have a facility where you can see people, take out a fish hook, fix a swollen ankle, deal with a this or a that, and make sure that Granny is in her apartment and she's well. So maybe send your nurse practitioner in every 3 weeks to make sure she's okay, so she doesn't dwindle and then end up in emerge. That's actually the biggest thing. And then, of course, we have this backlog of poor folks who have hidden illnesses that have not yet surfaced that we're going to have to deal with. That's a whole other topic.
Right. We'll have to have you back.
Anytime.
Yes. Well, one of the messages that I'm hearing, and is certainly is a takeaway for me, is that so much of what you're talking about is, not only the visioning, but is preventative. As you talk about, funding more into home care, which would actually prevent much more of these individuals entering the healthcare system in the first place, or even things that we've seen limited exposure to but benefit of, for example, paramedics and others doing routine healthcare checks on folks, and which also breaks down that whole experience of isolation. So, David, this has been or Dr. Walker. David, thank you. I feel like after this this has been an incredibly enriching conversation. And so I think to all of our guests who have joined us today from across the country, I want, on behalf of them, to be able to say thank you for your presence and presentation, and thank you for all of you for joining with us. If you have a moment to share your thoughts about the webinar or suggest a future topic or speaker, we'd ask you to fill out the webinar survey, which will be in the Zoom follow-up link. And I'd also like to mention is that we're also supported by our membership and donations. And so if you are a member, fantastic. We'd invite you to make a donation. If you're not a member, please join and make a donation. And you contribute to these ongoing educational programs. And then finally, our next webinar will take place on October 16th at 3 p.m. with Kevin Perkins from Farm Radio International to talk about the use of radio technology to deliver communication justice in Africa. Check out our website, and if you have any further questions for David Walker, you can please submit those, and we will endeavor to have those answered as well. So once again, David, thank you for your expertise and presence with us today. Have a good afternoon, everyone.